Welcome to this first module of musculoskeletal assessment. Here we're going to examine the cervical spine. As in all modules, we will use the Hippie-Rohn model, starting with H, our history, OPQRSTUV. What is the onset of the cervical pain? Was it sudden? Was it a chronic onset? What provokes the pain? What makes it better? What makes it worse? What is the quality of the pain? Is it burning, throbbing, crushing, aching? Does the pain radiate from or to another site? What is the specific site of the cervical pain? What is the timing of the pain? Does it come at night, in the morning, after certain activities? Is there an underlying motive for your patient complaining of cervical pain? And it's always important to get vital signs: temperature, pulse, respiration, height, weight, and blood pressure. As in every assessment of joints, we use the Rabbit-Men mnemonic. Is this referred pain? Is this an arthritis? Is this bone pain? Is this bursa pain, if there's one present? Is this tendinous, as may happen in a whiplash type injury? Is it a muscle problem? Is there an effusion, as in this paravertebral soft tissue swelling due to a retropharyngeal abscess? Is it a nerve problem? It's very important that we use this Rabbit-Men mnemonic in every instance of our differential diagnosis of joint problems. Our inspection includes visual inspection to determine if there's an antalgia, if there's a leaning away from or into the pain. Antalgia is simply a condition in which there's a posture. Is there a cervical deformity? Is there redness in the cervical spine? Is there swelling? Rubor color dolor is a term that we use to describe redness, heat, and pain, which denotes some infectious process or an infection. If the antalgia, if the head is tilted away from the pain, then we would suspect nerve pain. If, however, the antalgia is toward the pain, we suspect muscle pain. Palpation is going to include the spinous processes, the occiput, the mastoid processes bilaterally, the hyoid, and the thyroid cartilage. Soft tissue palpation will include sternocleidomastoid, making certain that we palpate from the sternum to the mastoid, the ear, the mandible, and paying particular attention to cervical nodes, the trapezius, the suboccipital triangle, which includes three muscles: rectus capitis posterior major, obliquus capitis superior, and obliquus capitis inferior. We also want to make sure that we palpate the superior nuchal ligament. The nuchal ligament, which is also referred to as the Pax wax, is a fibrous membrane which in the neck represents the supraspinal ligaments of the lower vertebra. It is unique to human beings and is required by bipedal mammals for running. Percussion involves gently tapping the spinous processes to rule out infection or fracture. And we also want to look for incidental, fortuitous, or chance findings, as is demonstrated in this coronal T1 weighted and T2 weighted MR image, which shows a fusiform shaped mass. Next, we want to measure range of motion of the cervical spine. Flexion normally should be 45 degrees. Extension 55 degrees. Lateral flexion between 40 and 45 degrees. And rotation between 70 and 80 degrees. Our orthopedic exam involves several tests, and we use the mnemonic, "A determined doctor of clinical sciences studies vigorously," to help us remember these site-specific cervical exams. First, the A stands for Adson's test. Adson's helps us to determine the presence or absence of thoracic outlet syndrome. Please study these charts or these pictures, read the information, and then pause the presentation, and then practice this maneuver on a partner. The first D stands for depression. The second D for the distraction test. The C for the compression test. The first S for swallowing. This is a simple test in which you simply ask the patient to swallow. Pain upon swallowing may indicate a mass or spurs. The second S is for the Soto-Hall test. And the V is for the Valsalva test. This list of tests is certainly not exhaustive. However, these will help you to determine the cause of the cervical pain. Next, we want to conduct a neurological exam by cord level, and first we will assess reflexes. C5 is responsible for the biceps reflex through the axillary nerve and the deltoid muscle. Look at this graphic. C6 is responsible for brachioradialis reflex through the musculocutaneous nerve and the biceps muscle. Pause the presentation and examine this graphic. C7 is responsible for the triceps reflex through the radial nerve and the triceps muscle. There is no reflex associated with C8. C8 innervates the finger flexors. And there is no reflex associated with T1. T1 innervates the interossei through the ulnar nerve. Examination of the motor response. Flexion is achieved by sternocleidomastoid through cranial nerve 11. Extension through the paravertebral muscles and the posterior rami. Lateral bending through the scalenus muscles and the anterior rami. And rotation through sternocleidomastoid, cranial 11. It's also important to test dermatomes. It would be wise to examine a complete 3D dermatome chart and memorize these cervical nerve root innervations. Then finally we move to examine related areas: the nose and throat, the chest, the shoulder, and the upper extremity. And this concludes our Hippie-Rohn model for assessment of the cervical spine: history, inspection, palpation, percussion, incidental findings, range of motion, orthopedic, neurological, and examine related areas. And this is the end of the cervical spine assessment.